Hello everyone and welcome to our module on eye movements. Let's begin by reviewing the extraocular muscles and the effects that they have on the eyeball. In order to do this, I've drawn an eyeball in the middle of the screen. There's a nose on the right side of the screen, and the left side of the screen represents the lateral or temporal portion of the face. So the lateral rectus muscle moves the eyeball laterally, and the medial rectus muscle moves the eyeball medially. These two muscles are very easy to understand. The major effect of the superior rectus is to move the eyeball superiorly, and the major effect of the inferior rectus is to move the eyeball inferiorly. The oblique muscles have a complicated effect on the eyeball. An easy way to remember them is that the superior oblique turns the eyeball inward and downward, and the inferior oblique turns the eyeball inward and upward. You may notice that I've used different colors to represent the muscles on the screen. All the muscles shown in blue are innervated by cranial nerve 3. The one muscle shown in red, the superior oblique, is innervated by cranial nerve 4, the trochlear nerve. And the one muscle shown in green, the lateral rectus, is innervated by cranial nerve 6, the abducens nerve. And many medical students remember the innervation of the extraocular muscles using the chemical formula LR6SO4. This stands for the lateral rectus muscle innervated by cranial nerve 6, the superior oblique muscle innervated by cranial nerve 4, and all other muscles are innervated by cranial nerve 3. And then finally, cranial nerve 3 also has additional effects other than moving the eyeball. That includes raising the eyebrow, and in addition it carries parasympathetic nerve fibers which constrict the pupil. For the USMLE Step 1 exam, it's very unlikely they will ask you what individual muscles of the eye do. Instead, they will want you to be able to diagnose nerve palsy. So for example, if a patient has a third nerve palsy or a fourth or sixth nerve palsy, they will want you to know how to recognize this based on examination of eye movements. And all of these nerve palsies can occur in various CNS syndromes, including strokes and tumors and aneurysms. Before we get into the individual nerve palsies, let me do two things. First, let me review some terminology. When we move the eye away from the nose, we call that lateral motion of the eye. We also call it abduction or abduction of the eye. When we move the eye toward the nose, we call that medial movement of the eye. It's also called adduction or adduction. And then the second concept that's important to understanding nerve palsies of the eye is the symptom of diplopia. Diplopia means seeing two different images of the same object. This is a picture of what it can look like on the screen. And diplopia occurs in many of the eye palsies that we'll discuss. And you should know that the diplopia that occurs in nerve palsies of the eye is always binocular. What this means is that the diplopia is only present when both eyes are open. It resolves when one eye is covered. So when a patient presents to clinic with diplopia, one of the first things you do is ask them to cover one eye and see if the diplopia goes away. If the diplopia persists when the patient covers an eye, that is monocular diplopia. That's usually a lens problem like astigmatism. In all of the nerve palsies we'll discuss in this module, the diplopia goes away when the patient covers one eye. That's because it requires both eyes for the diplopia to occur. Therefore, it is said to be binocular. The first nerve palsy we'll discuss is an oculomotor or third nerve palsy, and in order to understand this, let's review what the oculomotor nerve does. First of all, it moves the eye up and medially. It moves it up via the superior rectus muscle and medially via the medial rectus muscle. It also elevates the eyelid via the levator palpebrae muscle, and finally, it's responsible for pupillary constriction via the sphincter pupillae. This is not a direct result of the oculomotor nerve. However, parasympathetic fibers from the Edinger-Westphal nucleus travel with the oculomotor nerve, and therefore when there is damage to the oculomotor nerve, there can also be damage to these parasympathetic fibers, and that can be a problem for pupillary constriction. So if you understand that, it's very easy to understand what an oculomotor nerve palsy looks like. On the affected side of the body, the eye will be down and out as shown in this picture. There will be ptosis, which is eyelid droop, and the pupil may be dilated. When a patient presents with a third nerve palsy, it's very important to determine whether or not the pupil is dilated. This is called the rule of the pupil. So patients with a cranial nerve 3 lesion will have an eye that is down and out as shown in this picture on the screen. If the pupil is dilated, this means the parasympathetic nerves that travel with cranial nerve 3 are impacted. These fibers run on the outside of cranial nerve 3, and therefore they are easily compressed by a mass, especially a posterior communicating aneurysm. For this reason, if the pupil is dilated, you must consider that the patient may have an aneurysm, and that patient often needs imaging of the brain. If there is an absence of pupillary dilation, this suggests ischemia is the cause. Cranial nerve 3 ischemic damage is very common, especially among diabetics. They will present with a third nerve palsy, but they will spare the superficial fibers to the pupil, and therefore the pupil will not be dilated. Thus, the rule of the pupil is very important when evaluating cranial nerve 3 lesions. The next nerve palsy we'll discuss is a trochlear nerve palsy, or a nerve palsy of cranial nerve 4. This cranial nerve innervates a single eye muscle, the superior oblique. The job of the superior oblique is to turn the eye down and in. This is especially important for activities like reading or descending the stairs. Patients who have trochlear nerve palsies will present with diplopia, and the eye on the affected side will be tilted outward. If we go back to this slide, the job of the superior oblique is to turn the eye down and in. If there is a palsy of cranial nerve 4 and the superior oblique is not functioning, the result will be that the eye will be turned outward. This will make it difficult for the patient to look down and in, and this is especially a problem when activities are done like descending the stairs or reading. To compensate for this eye problem, the patient will often tilt their head away from the affected side. If you look at these eyeballs on the top right side of the screen, at the top I've shown what happens when there's a trochlear nerve palsy. The eye on the affected side is turned outward. In order to compensate, the patient will often tilt their head away from the affected side. This will correct the eyeball problem on the affected side. The other eye is normal and it can compensate, and thus the two eyes will be aligned properly. However, the patient's head will be tilted away from the affected side, and sometimes they actually complain of neck pain because they are constantly tilting their head in order to adjust their eyes and eliminate the diplopia. Our final nerve palsy involves the abducens nerve, or cranial nerve 6. This cranial nerve innervates a single eye muscle, the lateral rectus. When the lateral rectus does not function, the affected eye may be pulled medially at rest. In addition, problems are worse on horizontal gaze, because on horizontal gaze you need your lateral rectus in order to move the eyeball laterally, and the affected eye can't move laterally if there is an abducens lesion. So if we look at the bottom of the screen, I've demonstrated what can happen with a right cranial nerve 6 lesion. The right eyeball may be normal, or it may be pulled slightly medially depending on the severity of the lesion at rest. However, when the patient tries to gaze to their right, the left eyeball comes medially as it should, but the right eyeball is stuck and cannot move laterally, and thus the diplopia gets worse on horizontal or lateral gaze toward the side that is affected. As I mentioned before, if there is a severe cranial nerve 6 palsy, the affected side can have an eye that is pulled medially. This is a condition known as astropia. It's a type of strabismus. Strabismus is a misalignment of the eyes. In astropia, there is an inward turning of one or both eyes, and this can be seen in cranial nerve 6 palsy. At the bottom of the screen, I've shown you an example of astropia. This could occur with a severe cranial nerve 6 lesion on this side. The eye is pulled medially because the lateral rectus muscle is not working properly. One potential cause that you always want to think of when you see a description of a cranial nerve 6 palsy is pseudotumor cerebri. I discussed this condition in detail in the module on ventricles and sinuses. Pseudotumor cerebri occurs when there is high intracranial pressure. This can lead to a cranial nerve 6 palsy. The course of cranial nerve 6 is highly susceptible to pressure forces when the intracranial pressure becomes elevated. Sometimes high intracranial pressure can lead to a bilateral cranial nerve 6 palsy. There may also be papilledema on fundoscopy, especially in a board question. And the classic demographic that develops pseudotumor cerebri is an overweight woman of childbearing age who presents with headaches and a cranial nerve 6 palsy. The diagnosis you want to think of in that situation is pseudotumor cerebri. And that concludes our module on eye movement.